All right, everyone, we'll go ahead and get started on chapter 36. This is over geriatric emergencies. This will be a two-part video. The exciting thing about this chapter is one, I'm going to say literally 80% or more of the calls that you'll run in EMS are on geriatrics. So geriatrics remaining, pertaining to, an older population, 65 or older. And so we run a lot of old people because old people are sick and old people need ambulances and old people need to go to the hospital. And so that's not surprising. We run a lot of old people. But what I like about this chapter is it's a really good review right before we're getting ready for the National Registry and the final exam to review some of the high yield concepts. We've already talked about everything and almost everything in this chapter as far as pathology goes. But we'll talk about some specific stuff as it relates to geriatrics, like osteoporosis and aging and the heart and all these other things. But it's a very good review chapter. Okay, so like I said, geriatrics is pertaining to someone that's older than 65 years of age. Geriatrics present special challenges for healthcare providers, and so uh, we run these patients so often. It becomes the bread and butter. Like this is what you're going to run a lot of, and it doesn't matter really for the most part what type of doctor you are, a nurse or whatever. You just take care of a lot of geriatric patients. And so the injuries and illness are affected by chronic conditions, multiple medications, and the physiology of aging, probably more so the pathophysiology of aging. And so, these patients are chronic. They've had heart disease that's lasted all their life, for the majority of their adult life, and now into being in geriatrics or being old, it just gets more severe and more profound. And so eventually, this can create, these chronic conditions can manifest themselves acutely, like heart failure and all these other things. We'll talk about asthma, COPD. And so these patients just become sick. I mean, they're really sick patients. And, it's not uncommon. I'm always surprised, even in the clinic, when you'll see these patients and they have like two lists of medications. You're just like, oh my gosh. And so they take a lot of medications. We call that polypharmacy. And so we'll talk about it. So, the thing is, the geriatrics, just like pediatrics, they're not necessarily just old adults, right? They're not adults. They're geriatric. They're older. And so we have to look at them. They're specialized. They have really some fairly unique pathophysiology. Like you're not going to see osteoporosis in someone my age, right? But you're going to see osteoporosis in the old ladies, and it's common. You're not going to see dementia in someone my age, but you will see dementia in old people. It's common. And so these are things that when you start seeing these common conditions that only happen in this population, the old population, that's what makes it kind of unique. And so it takes time and patience to interact with an older person. I'm probably the least patient person on this planet. And so sometimes I really have to sit on my hands and just move slow. I've actually been guilty before early in my career trying to rush geriatric patients. Like, let's go, let's go, let's go. It doesn't work. You're just going to make them mad. So, you really have to be patient and thoughtful and methodical with what it is that you're doing. Of course, I wasn't trying to be disrespectful, and I wasn't disrespecting them. Just realize you really have to be patient. They move slower. Okay, you'll learn when we talk about the physiology of geriatrics. Everything's slower, and so that's kind of the issues of geriatrics. And so there's this thing called ageism. So just like racism, where you discriminate against someone versus their race, which is terrible. The same thing can happen in age. So this is where someone will discriminate on someone based on their age. You can actually see that. I mean, actually, I'll tell you, I was at a conference where there was literally 2 days ago, where there was a presenter presenting what's called reverse ageism, where it was an older man who was hating on people my age. And I'm like, it's just a crazy thing to do to discriminate on someone on their race or their age or their sex or whatever. It's just crazy to like stereotype that group of like that many people and say that they're all the same. It's terrible. And so just be aware, obviously ageism is where the young will discriminate against the old, but there's something called reverse ageism where the young will discriminate or the old will discriminate against the young. They're both wrong. They're terrible. They shouldn't do that. So not all old people have dementia. Okay, remember dementia is pertaining to memory loss, sometimes lack of coordination, but not all people have dementia. Not all old people are hard of hearing. Okay, not all old people are sedentary or immobile. Okay, I mean that shouldn't be surprising, but I mean yeah. So and this is the idea of stereotypes. This is like saying, all young people are disrespectful. All young people, all they do is play on their phone. It's just such a broad statement that's just not true. And so these are unfortunate stereotypes. Now, with that said, these stereotypes do have there's a reason stereotypes are stereotypes. yeah, there are a higher percentage of the older population that are demented. There are a higher population of the older population that have a hard time hearing or immobile. And so, but again, we shouldn't label people based on stereotypes. That's discrimination, that's bias. It's wrong. We're better than that, and especially as healthcare professionals, we're much better than that. We're better than the average person, right? We're the best of the best, and or at least we strive to be. And so effective verbal communication skills are essential. So let me tell you real quick, these are tested. Okay. I will promise you these will show up on a quiz and or exam coming to you. And so I find it very odd. This is what's tested, but this is what the Q banks go after. So it's really weird. They'll be like, you're communicating, they'll give you this long paragraph about an old guy or an old person, and they'll say, how do you most appropriately communicate? Or which of the following is not appropriate when communicating? So do know these do show up. So to communicate effectively with an older adult, you're going to speak respectfully, identify yourself, be aware of how you present yourself, look directly at the patient at eye level. This is really any patient, and speak slowly and distinctly. Hunter Harbold struggles with this one. I speak very fast, and so even like when I'm presenting or teaching, I'll be like, all right, slow it down, and it lasts about 5 seconds because that's my default. I talk fast. So it's very, very hard to slow that down. But when I talk to an older person or an older patient, I really have to like at the very front of my mind, be thinking slow, slow, slow. So just something to think about. Have one person talk to the patient and ask only one question at a time. And so someone like me, you could probably hit me with several questions at once or a loaded question, and I can usually fire off an answer. But it's going to be very difficult with someone who's older. That might not have as great of cognition as someone like myself and at 29 years of age. It's just there's a cognitive decline as we age generally, and so you're going to overwhelm someone. And so the other thing is this is a really powerful tool that should apply for everyone, but you should only ask one question at a time and have one person talk at a time. Okay, and so you really I've seen it where it's like, sir, you have shortness of breath, and like my partner's like, sir, do you have chest pain? Sir, are you? And it's like, it's too much. So one voice at a time, and you'll actually see this in trauma settings too, like in the back of an ambulance. Like if so I used to work at Cooks, and we used to have to say all the time there'd be so much commotion in the trauma bays and the resuscitation rooms. One voice and that's me, right? Like the doctor would have to shout out one voice and that's me, or the nurse, one voice and that's me. And then so that's the cue for everybody else to be quiet. This person needs to talk. It's very important what they need to say. And so do not assume that all older patients are hard of hearing. I would say it's generally better for you to speak normally and then sim to say, I need you to speak up. Okay. Give the patient time to respond. Listen to the answer. Hunter Harbold is impatient, and he also tends to interrupt people when they're speaking. I'm impulsive. It's something I work really hard at to fix, but you should wait for them to finish speaking before you respond. Explain what you'll do before you do it. Really, these are things we should do to everyone. And some general best practices. So the geriatric population is predisposed to a host of problems not seen in youth. And so hip fractures are very, very, very common. Okay. And so remember, a hip is not necessarily the pelvis that's fracturing. This is the pelvis right here. This is the pelvis, and this is the femur that attaches. And then, so this would be the femur drawing down. And it's showing you right there. And so what happens is they fall and they break their hip. That's very, very, very common. You run this almost every shift. I'm not kidding. You run this a lot of hip fractures, and they're very, very painful. And the interesting thing about a hip fracture is it doesn't necessarily kill the patient today. An isolated hip fracture will not kill you. Generally, if you fall on the floor and we get there pretty quick, you're not going to die immediately. But what does happen is they have to hopefully undergo surgery, and so surgery is a huge stressor on the body. And then they might get, and then from the surgery they could get infection, or they could get a bed sore, or they could get, and even if that doesn't happen, they go to a nursing home. Well, then they go to a nursing home, and now they're immobile, and then they have to go through physical rehab, and then this can take months and months and months. And then if they're too weak or they have too much pain, they can't rehab, so now they're wheelchair bound, and then they're sedentary, and then they have muscle wasting, and then their heart gets weak, and then they get pneumonia, right? And so the thing about a fractured hip in an old patient, hip fractures don't kill people. What kills them is what happens after that hip fracture, and it's usually from a decrease in physical activity, just from the recovery. This is very major surgery that takes it's not easy to recover from this. And so, the risk of infection and the risk of weakness and immobility and all the issues that come with this, blood clots, create all these problems that kill patients. So, you see this quite often. It's very sad. You'll see the 82-year-old male who lives at home alone, and he fell and broke his hip in the driveway. And I remember thinking like, oh wow, like you're not coming back home, because that's our goal. We want them to go home, but it's just very hard for these patients to get rehabbed appropriately. I'm not saying it's impossible; it definitely happens, but this is very commonly their demise. And like I said, they don't. The medical examiner doesn't write died of a hip fracture. The medical examiner will say died of a septic joint, died of aspiration pneumonia or whatever they come up with, right? And so, or pulmonary embolism. So just know this kills patients eventually. Okay. So more likely to occur when the bones are weakened by osteoporosis or infection. We'll talk about what osteoporosis is, but I'll tell you now it's thinning of the bones. This happens in old people, specifically old women. Sedentary behavior can lead to pneumonia and blood clots. So again, it kills them from like a blood clot or like their heart gets weak or whatever. So common conditions that lead to cause of death in the geriatric patient. So hypertension, remember that's the word for high blood pressure. Arthritis, so this is going to be inflammation in the joints. You'll see this most commonly in the fingers, the wrists, the knees, the elbows, shoulders. Heart disease, cancer, diabetes mellitus, asthma, chronic bronchitis or emphysema. What do we call that disorder? What is this disorder called? Right? COPD, chronic obstructive pulmonary disease, and stroke. So those are common conditions, but what's commonly killing them, the leading causes of death is heart disease. Okay, the heart will fail, cancer, injury, again like a broken hip, chronic lower respiratory disease can be from COPD, stroke, Alzheimer's disease, diabetes mellitus, accidents, influenza, and pneumonia. Okay, influenza means flu. That's the virus that causes flu. And so the aging process is accompanied by changes in physiological function. So all tissues of the body undergo aging. Okay, and so uh, decrease in the functional capacity of various organs systems is normal, but can affect the way a patient responds to illness. And so, I'm fairly young right now and healthy, and so I'm going to respond differently to the flu than an 88-year-old lady. And so, something to be aware of is as we age, your cells will not be replicating as quickly. They will not be as robust. They will not be as elastic. They're just not going to be as healthy. And sometimes they just stop replicating. And so these are all things that lead to people aging poorly, and this can lead to a system demise that becomes systemic. I'll give you an example, like the kidneys. If my kidneys were to be injured right now, they're gonna probably hopefully bounce back. I'm young, but again, an 88-year-old lady, if she has an acute kidney injury, she may not bounce back. Those kidneys are done at that point, and so then she has kidney failure, which is going to lead to pulmonary. It's a systemic overload, which is going to stress the heart and the lungs. So it's just, and then the liver, and so it's just the systemic, thing that happens when your cells stop. They're aging and they're not reproducing as they once did, or I should say replicating as they once did. And so age-related changes can predispose an older adult to respiratory illness. So again, these are tested. They'll say like, which of the following is a common cause of respiratory illness in older adults, right? And so the airway musculature becomes weakened. So this includes the ones in the throat. So we'll see obstructive sleep apnea, the risk of choking. Swallowing is a very complicated maneuver, believe it or not. And so as we age, the muscles can become weak and uncoordinated. And so not only that, the rest of like the diaphragm and the intercostal muscles, these can become weak. So an old lady cannot breathe at 60 times a minute for an hour, and I might be able to. And so these are just things to keep in mind. The alveoli and the lung tissue become enlarged and the elasticity decreases. What? That sounds like emphysema. That sounds COPD. Well, the interesting thing is, if we all live in an urban environment, so as we age, we end up with COPD to a degree as we age. This is a known phenomenon in the United States, in the Western Hemisphere. And so as we age, you're essentially being exposed to smoke, right? Exhaust, cigarettes, environmental toxins, occupational toxins that are going to lead to a degree of COPD over your lifetime. Okay, and so old people will have a degree of COPD by default just from life exposure. Not only that, you have to keep in mind in the 50s, 60s, 70s, 80s, even the 90s, and perhaps the early thousands even, smoking was very cool. It was very, very accepted. And so a bunch of older people smoked, not realizing the health effects that would have on you, or at least not appreciating that. And so you see a lot, I'm squirming. You see a lot of that where older patients used to smoke, you know. The body's chemoreceptors slow with age. So remember, chemoreceptors are these little sensors within the body that test. They're kind of sampling the blood and all its contents, kind of taking little sips here and there to test for like carbon dioxide and alcohol, and all these different pressures. Pressures are baroreceptors, but they're testing the blood, and so they're not going to respond as quickly. Again, as opposed to someone who's young. So you have a decreased cough and gag reflex. This becomes important with pneumonia. This also becomes important with choking. So if I were to swallow, a glass of milk, right? I'm drinking milk, and I feel it go down the wrong tube. It goes in my trachea instead of my esophagus. I'm going to gag. I'm going to choke. I'm going to cough, right? And the old people can't do that as well. Again, the act of swallowing is a very complicated system. Lots of nervous system involved, lots of little bitty muscles, lots of coordination. And so as we age, we lose that coordination just by natural aging, and especially when you throw in like diabetes and stuff like that, um, you can really lose that coordination. And so the chance of an old person coughing on, or I mean, sorry, choking, aspirating on like on a food or a liquid is very, very high. In fact, it's so high. If you ever go to a nursing home, you'll see, oh, they're on a puree diet or they're on a honey thick liquid diet. What does that mean? That means that they puree their foods to where it's in a pureed form, so like a mush. And same thing with like their liquids. So their water, even just drinking water, is honey thick. We put a gelatin in there to thicken it, where when they drink it, they're drinking very, very thick liquids. So hopefully they don't choke as likely. So again, pneumonia can be caused by virus, bacteria, fungal causes. The most common cause can be bacteria, strep, and then Staph aureus. And then so this is very, very common. Um, um, and so what happens is you'll get a bacteria down there, the body responds, it triggers inflammation, lots of pus, lots of mucus. And so, what sound do we hear with pneumonia? We hear rhonchi, right? It sounds like someone's breathing through a milkshake because they're breathing through pus. Okay. And so this is a leading cause of death from infection in Americans older than 65 years of age. Okay. Very common that people will die from this. Again, I probably, hopefully, will not die from pneumonia at 29, but an 88-year-old lady will absolutely die from pneumonia. Aging causes some immune suppression and increases the risk of contracting infections like pneumonia. There is actually a pneumonia vaccine. There's 3 of them. And so it's important that old people get vaccinated for this. But basically, the immune system becomes weak with age. Again, everything gets slower. The immune system's still there. It's just a lot slower to respond. It's not as powerful. It's not as strong. And so it's harder for them to fight off infection, you know. So basically in pneumonia, we'll get this increased mucus production, these pulmonary secretions, oxygen, and the infection all interfere with the ability of the alveoli to oxygenate the blood. So you can appreciate this picture, right? This is normal, right? These are our little sacs called the alveoli. This is where gas exchange takes place through simple diffusion. But if we have these puppies filled up with blood and mucus and snot and pulmonary and edema and fluid, yeah, you can imagine this is not going to do well with perfusion, right? You're not going to be exchanging a lot of gas through mucus. And so this is the problem with pneumonia. And so, if you have this old lady that already has a weak heart and terrible lungs, and you shut down half of her left lung, she's struggling. This can absolutely kill her. Okay. So the management of pneumonia is the same for any patient. You got to figure out what the infectious cause is, and then you have to treat it. Remember, what sound are you going to hear with pneumonia? It's rhonchi, rhonchi, rhonchi. So you're going to see rhonchi. Okay. And remember, pneumonia can be diffuse. That's not as common as it's typically what we call lobular or lobular pneumonia. So it's in a lobe, and so you might just have pneumonia down here. And so, in fact, in this picture, you can see it's down here in the left lower. And so, if you were to listen to this patient's back below their scapula, you're going to hear what sounds like they're breathing through a straw, through a milkshake. And we call that sound rhonchi. Also, keep in mind they would be having what's known as a productive cough. So this cough will not just be snotty boogers. It's going to be maybe white, brownish, dark green, blood. I mean, it's so this is not just like, oh, I coughed up some snotty boogers. This is going to be like, oh, you coughed up some like really nasty boogers. Okay, some pus, something like that. So productive cough is normal. But again, in older people, cough is suppressed. And so, they may not be able to cough this up very well. So again, it leads to further problems. So all these issues that come with pneumonia for old people. That's why it's so deadly. And so I'd ask you, student, what kills pneumonia patients, right? The most common would be probably sepsis. I don't know this for a fact. It's probably sepsis. Remember, form of distributive shock, overwhelming infection in the body reacts, causes widespread vasodilation, so the fluid leaks into the third space, so we call that distributive shock. It's sepsis, okay? And so what would be the second most common cause, or another very likely common cause of death with pneumonia? It's hypoxia, hypoxemia, right? The patient's not perfusing very well through this, okay? And so pulmonary, and then let me ask let me say the third one. Probably the third one would be respiratory failure. It's very difficult to breathe through that mucus, and their muscles are already weak, and so they could end up in respiratory failure from the increased work of breathing, the tachypnea, the dyspnea, the accessory muscle usage that will wear out eventually, and so they could end up with respiratory failure as well. So sepsis, respiratory failure, and then hypoxia, hypoxemia are the most likely causes. Now, pulmonary embolism, I've covered this extensively, but let's review. So basically, what happens is typically where this clot will start is in textbooks. It can start anywhere, but in textbooks, it'll start in what's known as the deep vein, okay, behind the knee. And so there'll be a vein over here by the knee that's deep, you won't be able to feel it, that will get a blood clot. Who typically gets this? People who are sedentary, people who lay in bed, people who are in wheelchairs, people who are truck drivers, flight attendants taking international flights, people who are sitting for a long period of time will get a clot up underneath the knee. Well, when that clot is stationary, we call that a thrombus. When the clot breaks loose and travels, we call that an embolism. Well, this will come up through the inferior vena cava, through the right atrium, tricuspid valve, right ventricle, pulmonary artery, and then it's going to launch out. And so in this case, it went to the patient's right lung, and you can see it's lodged right here. Well, the issue with this is when it's lodged like this, there's no blood coming to the area that this branch perfuses. And so that's called a pulmonary embolism. So remember, the ventilation is normal, but the perfusion, which is Q, is going to be decreased. Okay, so this is where you'll see decreased VQ mismatch. No, it's an increased VQ mismatch. And so just be aware of that. This is very common. And so how does this present? The patient will typically tell you they're short of breath, and they will almost always have clear lung sounds. So any patient that tells you I'm short of breath with clear lung sounds, it is a PE until proven otherwise. And it sometimes can have chest pain. This is going to be atypical chest pain, but examiners don't care. They will just say chest pain. And so remember, patients 35 years and younger typically don't have chest pain, like true cardiac chest pain. So if you have like a lady, just had a BBL and now she has chest pain and shortness of breath, you might be thinking, oh wow, this could very well be a pulmonary embolism. Okay, and so it can be confused with cardiac lung or musculoskeletal problems. So this is a confusing diagnosis, but this is nonetheless a life-threatening emergency. How do we treat this? Oxygen and a transport to the hospital. And so the risk factors for pulmonary embolism is living in a nursing home. Again, you tend to be more sedentary in a nursing home and or wheelchair bound. Recent surgery, again, after recent surgery, you tend to be sedentary. Not only that, your body is an inflammatory response. So your clotting factors will be increased, namely platelets. And so you have an increased risk of blood clots, okay? 3, history of blood clots or heart failure. If your heart's not pumping well, it's not going to be moving venous blood well enough, and so you could have a clot. Presence of a pacemaker or central venous catheter. The second one especially can cause what's known as phlebitis, which is inflammation of the vein. So that could also cause a clot. Obesity or sedentary behavior, right? So if you're overweight or if you are sedentary, what does the word sedentary mean? This means someone who is inactive, someone who is just lazy, flojo, right? Like they're just staying around the house, like they don't do much. They're sedentary, okay? Recent long distance travel, again, watch for the classic vignette of an across-the-road trucker, a flight attendant, someone who took an international flight, someone who's on a long road trip, etc., etc. Trauma, cancer, and or paralyzed extremities can all increase the risk of PE. And so PE presents with tachycardia, sudden onset of dyspnea, shoulder, back, or chest pain, cough, syncope in patients in whom the clot is larger, and anxiety. So let me show you this to you one more time. Remember, this clot starts down here in the leg, or it can start out on the leg, comes up through the iliacs and into the inferior vena cava. Well, what happens, this is coming out right here, right? It goes up through here, right atrium, tricuspid valve, right ventricle, pulmonary artery. Well, What happens if you have a clot that's so big it sits right here, right? It's a big clot. That's called a saddle thrombus, and it will kill them almost instantly. Okay, and so that is a very, very severe manifestation that does happen. And where you typically see with this, interestingly, is they will be blue from the nipple line up. Okay, what you'll also could have is this: if the clot's sitting here and you just knocked out the entire right lung, right? So you're not getting any blood flow to the right lung. They're going to be short of breath, tachycardic, tachypnic, and on their way to dying. Okay. Now, when I've seen this traditionally, the patients are very, very anxious. Very, very anxious. Okay. One thing I'll add that's worth knowing is women who take birth control are at a higher risk, especially if they smoke and over the age of 35. They are at a higher risk of blood clots. I actually had a friend who had a blood clot um, from taking birth control. And so pulmonary embolism presents with, again, apprehension. So if they're apprehensive, they're like worried or unsure is probably a better word for apprehension. Low-grade fever is possible. Hemoptysis. What does that mean? Hemoptysis means coughing up blood. Hemoptysis. Leg pain, redness, or unilateral pedal edema. Okay, so again, when that blood clot's sitting down in the right leg or the left leg, below that blood clot, there's going to be increased venous. There's going to be what's called venous stasis. The venous blood in there is sitting, and so that leg will become swollen, hot, and it'll hurt. It'll be achy. Fatigue, and then like I said, it was just, with a saddle thrombus, cardiac arrest. Okay, I've actually seen this. Had a guy call us, shortness of breath. We got there within like a minute. I was starting an IV on him in the back of the truck. We immediately put him in the truck. Within a minute, he was in cardiac arrest. So he blew literally from the nipple line up, just like the movies. Like it was it was an Alito. So it's a very tall tale case of a PE. Okay. Now the heart hypertrophies with ages. What does the word hypertrophy mean? It means it's the same amount of cells, but the cells just got larger. So if your heart cells are normally this big, with hypertrophy, that's 10, they're going to look like this. You still have 10 cells there, they're just bigger. Okay, and so this is actually what happens in your bicep if you go to the gym, or your legs or your glutes or whatever. Same amount of cells are there, they're just bigger. Okay, and that's called hypertrophy. And so what happens is the heart has to pump against hypertension, right? Increased peripheral vascular resistance. And so it's pumping against something that's more difficult to pump against, it'll adapt. It'll get bigger. It'll get stronger. And so when cells are stressed, whether you're at the gym curling or whether your heart is pumping against high blood pressure, it adapts, and so it'll get bigger. And so that is what hypertrophy is. And so where does this typically happen? Typically with the left ventricle. Because remember, the left ventricle is what's pumping blood all the way up to your head and down to your big toe. So you can see what's called LVH, left ventricular hypertrophy. And so the cardiac output declines. You're like, what, Hunter? You just said it got stronger. Well, no, what I said was it's adapting to stress. And so these cells will get bigger, but they're not necessarily getting stronger. In fact, these cells can get so big, they can actually decrease the diastolic portion of the heart to where the heart really just can't relax very well. And so you have a decreased cardiac output and stroke volume. And so there's a huge issue with this that happens in old people. Why do old people get hypertension? We don't know. We don't have a great answer. And so if we did know, let me know. I'll cut a deal with you and I'll give you half. So arteriolosclerosis contributes to systolic hypertension, okay? And so this word, arteriolosclerosis, or arteriosclerosis, this literally means hardening of vessels. Rip to my handwriting. And so what happens is what I was saying, that the systolic blood pressure is higher. It just happens with age. We have ideas, but we don't exactly know why this happens. And so the vessels will become hard. Okay. So now, not to compete, notice the difference. Arteriosclerosis or arteriolosclerosis, same thing. They're saying that the vessels become hard. Okay, it's hardening of the vessels. Not to be confused with its sister, atherosclerosis. Atherosclerosis means plaque, right? So this is like fat plaques built up in the vessels, okay? And so this is accumulation of fat and cholesterol in the arteries. And so the risk of this is you can get a big old heart attack, which is called a myocardial infarction, which literally means heart muscle dies, or a stroke, a cerebral vascular accident, okay? And so this is what it looks like. And so This is a normal artery, there's three layers, whatever. And so what happens in atherosclerosis, again, this is plaque, is you'll get what's called a tear in the intimal lining of which is the innermost lining of the artery. Okay, this happens in everyone. Okay, again, I'm 29. This has already happened to me. And so what happens is you get this tear, and if your cholesterol is high or relatively high, this cholesterol will settle up underneath that tear. And then so when that happens, it creates this inflammatory response. So these macrophages go in there and they're like, what the heck? There shouldn't be fat here. So they start chewing on the fat. Well, this creates more inflammatory response. So then more cholesterol has an opportunity to get up underneath there. And so this happens over a lifetime. And so this is how you get this big plaque formation. So imagine a fatty plaque up inside of a vessel. Well, this plaque can become so large it could occlude a vessel. One, two. What's more likely is going to happen is a clot could form. Like platelets will be like, why is there all this inflammation here? And so these platelets will come up on here and start grabbing onto each other due to the inflammatory response. And when that happens, you get a blood clot. This blood clot can become so large it can block off the flow, or it can launch off and go to a smaller artery and block that off. So remember, these clots that are stationary, that is a thrombus. A clot that is moving, that is called an embolism. And so that is the idea of this. And so what are the risk factors of this? Uncontrolled hypertension, type 2 diabetes, smoking, and high cholesterol. Who does that sound like? The people that we run. Okay, and so this is obviously a very big problem in the United States. It's the leading cause of death in the United States is heart disease, mainly because of what I just described. Okay, so older people are at an increased risk of formation of an aneurysm. What's an aneurysm? Remember, it's ballooning of a vessel. So that's what this is right here. It's a little balloon that pops off a vessel. This can happen anywhere in the body. It can happen in the brain, happen in the kidneys, happen literally anywhere. But the common example is in the brain and then the abdomen, which we'll talk about. And so as you can appreciate, this is going to be weak, right? This is a ballooning, and so this little guy just wants to pop, and so you could pop this, and when it pops, you're going to be bleeding. And so if this happens in the brain, we call that a hemorrhagic stroke, right? That's a subarachnoid bleed, or I'm sorry, an interparenchymal bleed. And so that's a form of a stroke. And so these patients, if it pops in your head, that can very well kill you, and you'll present with stroke-like symptoms. And then the blood vessels and heart valves become stiff and degenerate. So like disorders like aortic stenosis are very, 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 very common in old people. Okay. And so the valve, just from a lifetime of beating, will become stiff. And when it becomes stiff, it can lead to, when the left ventricle is trying to pump out against a stiff valve, it's really hard to pop it open to get blood to pop out. Okay, so that's the idea of like aortic stenosis. The valve becomes so stiff that the heart has to pump really hard to push blood out of this stiff valve. Okay, the heart rate becomes too fast, too slow, or too erratic, or D, all the above, and so all of those become problems. And so we've talked. This is artery problems, but we also can talk about venous problems. So venous stasis is very common. You'll see this on grandma or grandpa, or if you go to the Walmart, you'll see this in older people. And so remember, veins are carrying blood back to the heart. For the most part, they're deoxygenated blood, but veins have valves in them that look like this. And so when you push, you can push blood through it, right, back to the heart. Here's the heart. But the idea is to where blood doesn't go back the other way, so there's one-way valves in veins. Well, these valves can become damaged. The vein becomes engorged. So you can imagine, look, now these valves don't even touch because the vein's so engorged. So of course you're going to have blood can go in either direction at this point. And so, that's one of the ways this happens, or the valves just become sclerotic, or they become damaged, whatever. And so you can end up with venous stasis. So someone's stasis means to hold still or stand still. And so the veins are standing still, right? So there's just blood just static, right? It's just sitting in there. And so this will cause blood clots eventually. And so this is one of the many reasons that older people are at an increased risk of blood clots. And remember, if it's in the deep vein, it can cause, one of the places it can cause a pulmonary embolism, okay? But what happens more often is you'll end up seeing what's called venous stasis, okay? And so, anyone can have these, even young people will have varicose veins or spider veins. But I want you to see right here. See how the legs are like more of a reddish brownish color? This is actually hemosiderin deposition. This is a component of blood that has settled in the legs and stained the skin a brownish red color. And so this is a tall tale sign of venous stasis. Very, very common. I'm willing to bet if you look at, most of the patients you run, they will have, their legs will look like this. Okay. So, in fact, this can become so static, you can get what's called an ulcer, and that's what they're showing right here. And so it'll be like an ulcer of the leg from venous stasis. And so that's venous stasis, very, very, very common. And it can lead to blood clots. Also, it can lead to all sorts of problems, but blood clots is probably the one that'll kill you first. And so the classic symptoms of a heart attack are often not present in geriatric patients. Okay, so remember who presents differently? Old people, which are geriatrics, so geriatrics, diabetics, and women. Okay, they present differently. So this is the guy that's like, I have heartburn. Okay, and you're like, oh, okay, why'd you call an ambulance for heartburn? And you get to the hospital and they're having a full-blown heart attack. Okay, and so be very, very aware of that. This is not anecdotal. This is not my opinion. This is something that you have to take very seriously. They present atypically. Okay, they will literally just tell you, I feel just a little dizzy. I feel just a little short of breath. I feel just a little nauseated. And you're like, okay, wow. Okay, nothing major here. And you get to the hospital and they do a picture of their heart and EKG and they're having this huge heart attack. Very, very common in geriatrics. So you can't rely on the traditional signs of like, oh, I have crushing chest pain, elephant sitting on my chest, radiating to my left arm and jaw. That doesn't happen in old people. It can, but it's very rare. It's more common that you're going to see these silent heart attacks, okay? Remember, this can happen in geriatrics, diabetics, and women. And so guess what? Imagine the geriatric woman who's also a diabetic. We run those people. And so, this is not uncommon to have like a triple whammy. Now, manifestations of acute cardiac disease. So dyspnea, remember that's the medical word for shortness of breath. Epigastric and abdominal pain. Remember the epigastric region is where we would think our stomach sits, right below the sternum. So again, it's not uncommon for them to be like, oh, I have heartburn. It's not heartburn. That's your heart. So your heart is burning. No, I'm just kidding. So just be aware of that. They'll present with vague symptoms like, oh, I have heartburn, or I have indigestion, or you know, my stomach feels funny, something like that. They could have loss of bowel or bladder control. Remember, the medical word for this is called incontinence. Nausea and vomiting, weakness, dizziness, lightheadedness, and syncope. Remember, this is the medical word for fainting. It's pronounced syncope, fatigue, or confusion. Okay. Now, other signs and symptoms of a heart attack could include issues with circulation. So they may have like a really weak radial pulse. Diaphoresis. What's diaphoresis, estudiante? It is sweating, right? It is the medical word for sweating. So these patients will have that nasty, slimy sweat, right? When you see a patient that's sweating when they should not be sweating, like it's not hot, that's ominous, okay? Where else do we see diaphoresis? What's the most common time we see diaphoresis? Hypoglycemia. Pale cyanotic or mottled skin. Remember cyanosis, the bluish tint of skin. Abnormal or decreased breath sounds and increased peripheral edema. I'm going to show you a picture of what this looks like. But, why would you see increased peripheral edema, right? This is heart failure, specifically the right side or congestive heart failure. Speaking of heart failure, so the signs and symptoms will differ depending on whether the left, the right, or both sides of the heart are not functioning properly. So typically the left side will fail, then the right, okay? And so right-sided heart failure occurs when fluid black, and what happens is fluid will back up into the body. So remember, the right side of the heart is accepting fluid from your brain and from your toe, and if it can't accept it because it can't pump it appropriately through itself, it's going to back up, and so it backs up in the periphery. So where this will most commonly settle is in the lower extremities. Why? Because of gravity. And so, you know, let me just show you what this is. This is called pitting edema. So this is called it's called tibial edema. And so basically what happens is you'll take the patient's tibia, their shin, and you'll push down with your thumb for like 3 seconds and let go. Normally that should bounce right back. There shouldn't be a pit. There shouldn't be a dip. But what happens when you have pitting edema, you have a pit. There's a dip. And so this is a very common assessment I do on virtually all patients, where I'll just check for pitting edema. And so this can be graded like +1, +2, +3, whatever. That's not important. Just say like, hey, there's significant pitting edema present in the lower extremity. Okay, and so this is an indicator of fluid backup. Okay, where do we see fluid backup? Left-sided heart failure or congestive heart failure. And so remember though, fluid can back up into the neck. Okay, so remember the heart is accepting fluid from the neck, blood from the neck, the jugular veins. And so if the heart can't accept the blood, it's going to back up, and you can see it back up into the vein or the veins of the neck. We call that jugular venous distension. You could also see what's called ascites. That's this word right here, ascites. Okay, this is where their fluid will up into their abdomen, so they'll have this big watery belly. Peripheral edema, that's what this is, and an enlarged liver, so we call that hepatomegaly. Okay, and so I don't expect you to find an enlarged liver in the field, but just be aware those are all. It's because fluid's backing up. Okay, the heart can't accept it. It's like, I can't pump it out, so it's just not going to accept it, and so it'll just back up into the veins and the vasculature. Okay, this is tested. So what's the most common cause of right-sided heart failure? It's left-sided heart failure. And so be aware of that. Test question. What is the most common cause of right-sided heart failure? It is left-sided heart failure. So it is common to see both. Now, left-sided heart failure is when fluid will back into the lungs. Remember, fluid from the lungs is traveling out the pulmonic artery the pulmonic vein into the left atrium, into the left ventricle, right? And so what's happening here is the left side of the heart can't accept that blood because it just can't pump it out. And so what happens is the fluid will back up into the lungs. So what sound does that make, right? What sound does it make when we have pulmonary edema? Crackles. What's the other word for crackles? They're synonymous, meaning they mean the same thing. Rails, okay? So it sounds like they're breathing through water, because they are. They're breathing through pulmonary edema. And so a patient will have shortness of breath, and not only that, they will not want to lay flat. If you lay them flat, they will become very anxious, and in fact, it could kill them. And so, you'll see these patients, if an informal judgment of, oh, how bad is your heart failure? You could say, how many pillows do you sleep with? So they sleep with like 6 pillows. Or you could ask them, do you sleep in bed or do you sleep in a recliner? Sometimes this is so severe they cannot lay flat, so they literally sleep in a recliner. And so it's characterized by a sudden attack. Oh, okay. And so this is what I was talking about. This is called paroxysmal nocturnal dyspnea. So paroxysmal means like a switch, like the opposite. And nocturnal means at night, and then dyspnea. And so basically what happens is when the patient moves to lay flat at night, they get short of breath. And so this has a word, it's called paroxysmal nocturnal dyspnea. And so what happens is the patient will try to lay flat or to recline, and they can't because they feel short of breath. They will literally tell you it feels like they're drowning. And so it's from a fluid accumulation in the lung, and the most common cause of fluid accumulation in the lung is left-sided heart failure. And so, sometimes they'll have coughing, they'll feel suffocated, they'll have the cold sweats, also known as diaphoresis, and tachycardia. So this is one of the many reasons. There's not very many reasons to lay a patient flat on an ambulance stretcher. I almost always will have them sit up, or at least partially be sitting up, for this reason. Okay. Not only that, if a patient presents with this, they will not let you lay flat. They won't let you do it. They will not lay flat. And so this is very, very common. And so what happens is you'll see patients in the middle of the night that call us for this. They get short of breath in the middle of the night from this because they have pulmonary edema. So they're like, oh, I woke up short of breath, couldn't catch my breath, heart rate's 120, stats are 88%, and you're listening to their lungs, and it's going to sound like crackles because they have pulmonary edema from left-sided heart failure usually. They could also be coughing up a pink frothy sputum. Okay, remember that. You could have that pink frothy sputum. What's the treatment for this? Sit them up, give them oxygen, and if allowed, you could give them CPAP or BiPAP. That's going to force that air into the vasculature. And so, or it's going to force the fluid, sorry. The leading, and open up the alveoli. So stroke is a leading cause of death in older people. It's the 5th most common cause of death in the United States. The same amount of strokes happen as heart attacks, around 800,000 a year. And so these are all preventable risk. Well, you can't prevent some of these, but these are risk factors, I should say. These are not preventable, by the way. Smoking, hypertension, you can't prevent diabetes. Atrial fibrillation, you can't prevent that. Obesity and sedentary lifestyle. So shout out JB Learning, job well done. You can't prevent some of those. Now you can prevent smoking and obesity, being sedentary. And so if you look at these, all of these actually would increase your risk of heart attack, with the exception of atrial fibrillation, would increase your risk of a heart attack. So stroke is a vascular disease. And so, what is atrial fibrillation? You'll hear this a lot, and a lot of old people have this, like a lot. And so, what atrial fibrillation is remember the heart has four chambers. The top is the atrium, and the bottom is the ventricles. Well, the atriums don't have a lot of muscle. These are just chambers that hold blood because all they're having to do is pump blood from the top of the heart to the bottom. And so, they're holding chambers essentially that have to squeeze blood a very short distance. And so, what happens is, um, you you um the in atrial fibrillation, the word fibrillate means to quiver or to shake. So instead of the heart going boom, boom, atrium, ventricle, like this, what happens in atrial fibrillation is the top of the heart's just quivering, right? It's just shaking like this, 300 times a minute, it's just shaking. And so what happens when you have atrial fibrillation is while the top of the heart's shaking, blood can become static in there. It can sit, and it can sit so long it can lead to a clot. When it leads to a clot, that clot, especially in the left atrium, can launch out through the aorta and travel up the internal carotids and up to the brain. If that happens, it's called a stroke. And so this is a very common cause of stroke is uncontrolled atrial fibrillation. So just a tidbit on that is very, very common. And so, but hypertension is the most common cause of stroke. Okay, and then followed by that would be but the most serious cause of this would be atrial fibrillation. Anyways, I don't get into that. But uncontrolled factors, you can't control your age, race, or gender. Okay, and so blacks, older people, or males, black older men are at a higher risk of stroke. Okay, and so just be aware of that. Not my opinion. Now, signs and symptoms, acute. So, what are the signs and symptoms of stroke? So, acute level of consciousness. So, you can have numbness, weakness, or paralysis on one side of the body. Okay. So, remember on this one, on the paralysis, weakness, we call that hemiparesis or hemiparalysis, and on the numbness, we call that hemiparesis. Okay. So you could see that on the exam. They'll say, "Oh, a patient has hemiparesis." That's the weakness. Hemiparalysis is the paralysis, right, on one side. But the numbness, the altered sensation, it's called hemiparesis. And so they'll have slurred speech, difficulty speaking, visual disturbances, headache and dizziness, incontinence, and they could even have a seizure. So remember the stroke exams, we have that be fast, right? So if a patient has lack of balance, lack of eye coordination, facial droop, asymmetry, right? So one side of the body is weaker than the other. Their speech is slurred. That's the S, and T is in time. This is very time sensitive. These patients you have to start the medication that treats this in less than 4.5 hours. And so this is where time is brain. So every minute, 1.4 million neurons die. That a stroke is left untreated. And so these are very, very sick patients. And so just be aware of that we need to be able to recognize stroke. And so we'll show, I think we've showed you how to do a stroke screening in class. If not, remind Amanda or Laura or Jeff. We'll do one on how to do like a fast screening and then, or I'm sorry, a Cincinnati stroke scale or an LA motor stroke scale, and then also a van screening. We'll show you how to do those. And so hemorrhagic strokes are less common and more likely to be fatal. In fact, okay, I'll just break the news. I taught this like 2 days ago at a conference. 13% of strokes are hemorrhagic. Okay, 87% of other strokes are ischemic. So what does the word hemorrhage to mean? It means to bleed. And so if someone's bleeding, this means they're bleeding within the cranium. So they're bleeding either within the brain or on an outer layer of the brain. And so we call that a hemorrhagic stroke. And so the thing about a hemorrhagic stroke, if I were to draw a table with time and symptoms, a hemorrhagic stroke, we'll draw this one red. It looks like this. They get worse and worse and worse until they die, right? There is no plateau because the cranium is a confined vault. As pressure builds up, you're going to have herniation, which means the brain gets squeezed and pushed around corners that it's not supposed to get pushed on. And so you'll end up dying. Okay, what respiratory, and this is where you see Beck's triad, right? So, wait, Cushing's triad. Pardon. It's Cushing's triad. And so this is where you'll see, remember Cushing's triad? Bradycardia, hypertension, irregular respiration. So that could be Biot's, Cheyne-Stokes, apnea-stick, those things. Okay. And so this is a terrible way to go. Okay. Very common, or not common. It's about 13%, but it sure is common. It does happen. Now, the other one's an ischemic stroke. And so this is where a thrombus or an embolism will launch off or be stationary and it blocks off the blood flow to a portion of the brain. This is much more common. 87% of strokes will be this way. And so the interesting thing about these types of stroke and ischemic stroke is that they tend to get really bad and then they plateau, right? Because once that tissue dies, it dies. And so that's something to be aware of, that if you'll see this clinically, okay? And so the treatment goal is to salvage as much time as possible and so, or as much brain tissue as possible. If the symptoms occurred within the past few hours, the patient would be a candidate for stroke center therapy. So there's several ways we can treat this. The first and most common way is if they're less than 4.5 hours since the last known well, meaning when these symptoms started or less than 4.5 hours ago, we can go in there and give them a medicine that dissolves clots, right? It's called TPA. So, the medicine is called TPA, tissue plasminogen activator. And then so that's the mainstay of stroke treatment, okay? But also if it's a really big, what we call large vessel occlusion, you can go in there with a device and do what's called mechanical thrombectomy. And so, or it's called an MET, mechanical endovascular thrombectomy. This is where you'll go through not you, but a neurosurgeon will go through an artery and they will go find that clot in the brain and they will literally yank it out and pull it out of the body. And so that can be done at very specialized hospitals. There's only 49 of these hospitals in the state of Texas right now. Okay, so these are going to be at big hospitals that can do that. Now, not to be confused with something else called a TIA, or transient ischemic attack. Now, if someone's transient, like a homeless person, they'll call them transients. This means it comes and goes. Okay, and so a TIA will present with stroke-like symptoms that resolve within 24 hours. Okay, so what does that mean? That means someone has a stroke and within 24 hours it resolves without intervention. And so these are the warning signs of a stroke, because what does that mean? That means 1 out of 5 patients will go on to have a full-blown stroke, right, that doesn't resolve. And so this is the chest pain before the heart attack, right? This is the warning sign before someone has a very, very big stroke and that you don't heal from, okay? Remember, central nervous system tissue, the brain and spinal cord do not regenerate ever. And so once you have a stroke and you've lost your ability to speak or lost the ability to use your right side or lost your ability to swallow or whatever, that does not come back, okay? And so just be aware of that. Now, changes in the nervous system with older people is they'll have a change, everything's slower, right? They'll have a change in thinking speed, which is cognition, right? They'll have a change in memory. Their memory's slower, not as powerful. Their posture stability, so they're not as stable on their feet, okay? Just the act of standing takes an incredible amount of coordination. The act of walking takes much, much more coordination and balance and brain power. Also, it's not a myth. This isn't being funny, but an old person's brain shrinks with age. It atrophies, literally. And so this can create its own problem as this shrinks, okay? And we've talked about this. You can get what's called a subdural hematoma. So if this is the layers of the skull, right? And so this is a normal brain. It's normally connected by these things called bridging veins. Well, what happens is as an old person ages, the brain will get smaller. So instead of being up here where it once was, now it's down here. And so these bridging veins get pulled really tight. And so if they fall and hit their head and tear one of these bridging veins, crack, right? They're going to end up bleeding in this space called the subdura. And so that's called the subdural hematoma. It's a form of a stroke. So where do you see a subdural hematoma? This is someone who fell, hit their head 3 days ago, and now they have stroke-like symptoms, because it's venous blood, it's not arterial blood, so it's lower pressure. And so just be aware, that's not a myth. Older and alcoholics, actually. Older people and alcoholics, their brain shrinks. Not my opinion. There is 5 to 50% loss of neurons in older people, okay? Now, with that, keep ageism in mind. It does not mean that they're stupid, dumb, right? Or, always cognitively impaired. So, of course, you'll treat them with respect, okay? The performance of most of the sense organs decline with increased age. What does that mean, right? So the sense of touch, hearing, smell, taste, vision, all our senses are decreased. So, older people, you'll get what's called presbyopia, which literally means old eyes. And so on top of if you've already had like hyperopia or astigmatism, whatever, but the word is presbyopia. And so you can get these old eyes that's just a matter of fact of aging, okay? So that happens. And so you can have change in visual acuity. The depth perception, so how deep an object is. So this can create a problem with falls, like, oh, I missed the step because I didn't realize how far it was, or I stepped, I didn't see the sidewalk. I didn't realize how tall it was. Stuff like that you'll see a lot. The ability to accommodate. What's accommodation? This is light. So the pupils won't constrict or dilate, which is accommodation, um, as robust as it should when you're younger. Okay, so think about that. You're outside, it's sunny. You walk into a dark house, or a dark room. As a young person, your eyes are going to accommodate and adjust. But old people, that doesn't happen. So again, it can lead to a fall because they can't see. So cataracts is clouding of the eyes. If you ever had an old dog, you could look at their eyes. It's very common in dogs. And so my dog, bless her heart, is starting to develop cataracts. We love her. And so this is clouding of the eyes. So you'll see the eyes become cloudy. Now, you can treat this in adults and dogs, but you can treat this with surgery, but it's not always done. Risk versus reward. Decreased tear production leads to drier eyes, not important. Okay, so you could have difficulty differentiating colors. Of course, you're going to have decreased night vision. If you've ever rode in the car with grandma at night, she can't see shit. She's like, I can't see. And it's like very scary because old people cannot see at night, especially my grandma. It's very scary. And so we love her, but it's like, oh, it's scary. It's a roller coaster getting into a car with her at night. And so a lot of older people just won't drive at night for this reason. Okay, they have decreased night vision. Because night vision does not occur in the fovea. It doesn't occur where normal vision takes place. Okay, it's actually in a different area. Anyways, inability to see close up. What? Presbyopia. Presby means old. Opia means eyes. It literally means old eyes. Okay. Other diseases like glaucoma. So what's glaucoma? This is increased intraocular pressure, right? So this is a problem that you can end up with in old people. Macular degeneration. So the macula has to do with vision, and so it can degenerate. So you can end up what's called a scotoma. And so if this is like your normal vision, like say you can see this, right? So like, let me go back. Oh, there's your grandkid, right? And so this is like the vision of your eye. A scotoma looks like this. It's just a black area in the middle. And so it creates like, that's a hallmark sign of macular degeneration. Diabetics tend to get that. And retinal detachment. We've talked about what retinal detachment is. This is a review. I know I'm going fast, but this should be a review. So if this is the back of the eye, and here's the retina, or I'm sorry, the fovea, okay? What happens is on this back part of the eye, there's this like lining called the retina, okay? Well, what can happen with age is this can detach, and so what happens is it starts, this isn't going well. It can start sagging. And so it can sag so much that it starts affecting your vision. So you could have sudden painless loss of vision in one eye. You could also have what's called a curtain falling effect, where it feels like there's a curtain falling in your vision because your retina is falling. It is detached from the back of your globe of your eye. Okay, and so people with repeated trauma, like boxers, are like the top G, Andrew Tate, as he likes to refer to himself. He has had retinal detachment. That's why he doesn't fight anymore. And same with like old people with like just vascular issues like diabetics and stuff like that can end up with retinal detachment. And so hearing, so we call this presbyacusis, okay? And so old ears. And so what happens is the inner lining of your ear has little hairs. And so when sound, remember sound's a vibration, and so sound comes in, it bends these hairs. And so we sense those vibrations as noise, and so that's carried back to the brain and we interpret it. Well, what happens is these hairs become stiff, and so and less common and like they're not as robust, and so they can become so stiff that you end up with presbyacusis. And so this is the risk of like long-term loud noises and also just being old, is these will become stiff, and so we call that presbyacusis. And so both of these are causes of hearing loss. Okay. And so not only that, but keep in mind that the ears, and another mechanism called the vestibula, sorry, it is like this figure eight figure that has endolymph inside of it. And so what that helps us with balance. And so old people can get what's called an otolith in here. They can also get this can just have less fluid or too much fluid. And so this can lead to vertigo. It can also lead to decreased balance because of this. Okay. And so these are all issues that you can get with old people. By the way, old people are my favorite. I literally love old people. They are so fun and genuine and just really, I just love old people. Like I would take hanging out with an old person all day than someone my age. They're so cool. So taste does change a little bit. And so, you can get the issue with taste change is this occurs over our life, but it can lead to a point where you could end up with like malnutrition and weight loss, and that will lead to fatigue because they're less inclined to eat because of taste. So right now, I'm very inclined to eat because I love the way food tastes. But if you're like, I don't really like the way food tastes, you're gonna lose weight. Touch. So there's a decreased sense of touch and pain perception from the loss of the end nerve fibers. Who's at a higher risk of this is diabetics. Okay, we call this neuropathy. Okay, and so remember, um, diabetics will get neuropathy to where they'll have like an abnormal sensation in their extremities, or just, and this can progress to something that's called which you don't, I mean, it's called a Charcot joint. And so basically the joint, they just can't feel it. And so that's very common in diabetics, especially old diabetics. They just can't feel their feet. They literally cannot feel their feet. Okay. And so, just be aware that's a huge problem with older people. And so the thing is, imagine if you kick the shit out of a wall, right? And you're old and you don't feel it. Like you have a Charcot joint, you have diabetes, it's uncontrolled, and like so you literally cannot feel your feet. And you kick a wall and you break 3 toes. These toes become infected, but you can't feel that pain. You can't feel that infection, right? This is where you can be injured and not even know it. Okay. And then so of course they could all as well have a decreased sensation of hot and cold. Now I want to say it could also be increased. Neuropathy could also be increased to where it's painful, right? So the normal sensation of like room temperature water feels like it's boiling to someone with neuropathy, right? That's a scenario. Or someone with, you know, that steps into a bath, it feels super cold. So that's neuropathy. Neuropathy is saying pathology of the nerves. And so this is very, 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 very common in old people. Very common. Now, this is commonly tested, so let's go. The difference between dementia and delirium. So you have to know, right? Say it 10 times really fast. Dementia, old people, dementia, old people, dementia, old people, right? Dementia is for old people. People my age do not get dementia. So if the vignette tells you they're 35 years old, do not pick dementia. It is wrong. Dementia is a slowly progressing, okay, slow onset of progressive disorientation, shortened attention span, and loss of cognitive function. What's cognitive function? Cognition is your brain's problem solving forward slash like daily activity stuff. So counting and reading and stuff like that. Memory. And so this is a slow onset. Okay. This takes a period over years. Okay. So if they tell you the patient was normal yesterday and today they're not, it is not dementia, or it is not dementia. It is delirium or something else, psychosis. So just be aware of that. Remember, dementia is long term, right? This is very slow acting. And so watch for that in vignettes, because what they'll do is they'll describe, 28-year-old male has low blood sugar and altered mental status and loss of cognition. What is this? It's not dementia. Okay, pick something else. It's psychosis or delirium. And so just be aware of that. So it's chronic, generally irreversible. In fact, I'd say it's fully irreversible condition that causes a progressive loss of cognitive abilities. Again, problem solving, counting, reading, memory, driving, shopping, things like that. Psychomotor skills, walking, again, driving, bathing, swallowing, things like that. And social skills, okay? And so dementia is the result of many neurological disease. Remember, dementia is a symptom or is a sign. And so um, it's like a broad, this is like saying, it's like the shortness of breath. This is the dyspnea of diagnosis, right? Like, so shortness of breath could be asthma, COPD, pneumonia, right? It could be a million different things. Dementia is that. It's a sign. And so, meaning something that you can see. And so, interestingly, patients with dementia often don't report it, right? And so, an interesting thing, when someone comes up to you and says, like an old lady, 78, I feel like I'm short of, I feel like my memory's slipping. That's called normal aging. That's normal. Dementia patients won't tell you that. They'll think that they're normal, right? And so, in Alzheimer's patients, or Parkinson's patients, someone with vascular dementia, something like that, they will not tell you, I walked into a room and I can't remember while I'm there. That's normal aging. but one of these patients with dementia, they won't report it. And so just be aware, Alzheimer's, okay, we're going into this. Alzheimer's protein deposition in the brain, okay? And so proteins get deposited in the brain, so it jacks up the brain, okay? This is genetic. This is terrible. Can be lethal. It's a terrible way to die. Very, 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 very sad condition, but this takes years to progress, okay? Parkinson's disease is loss of I can't speak today. Dopamine neurons within the substantia nigra. And so what happens is dopamine, and I'm going to put like it's less dopamine. Dopamine is involved in your coordination and your cognition, okay? And so, for example, if you're to snort cocaine, you're going to increase the amount of dopamine, so you get all hyper, right? But imagine if you take away all that too much dopamine, right? You can get these symptoms like what's called bradykinesia. So these patients move really slow. They have what's called a resting tremor, and sometimes I'll call it a pill rolling tremor. So it looks like they're rolling pills in their hand. They could have what's called a masked facies. So remember, there's a lot of work going on to make a facial expression or something like that. So they tend to have a very bland facial expression at all times. And so that's Parkinson's disease, okay? Again, progressive, takes years to progress. It is treatable, but not curable. Alzheimer's is also treatable, but not curable. Cerebrovascular accidents, also known as a CVA, this is the other word for a stroke, okay? So think about it. If you've had a stroke and you've killed chunks of your brain, you might have dementia, right? That would make sense. And then genetic factors. What are the genetic factors? Well, the first one is Alzheimer's disease, Parkinson's disease, Pick's disease. Those are all genetically related. Not only that, Down syndrome, very, very high incidence of early Alzheimer's and Down syndrome. For a reason, it's genetic. But what I'm saying is you could have a genetic factor to this as well. Now, could you have dementia and not have any of these diagnoses? Yes. And so remember, this is like saying you could have dyspnea but not have COPD, asthma, emphysema, you know what I'm saying, pulmonary embolism. You could still have shortness of breath, dyspnea. So yes, you can have dementia and not have one of these diagnoses, but dementia is it takes a long time, okay, and we can't really reverse this very well. So the onset of patients, patients may have short and long-term memory loss, okay, have a decreased attention span. One of the ways we test this in the clinic, not in the field, is called the serial sevens. You'll have someone count backwards backwards from like 70 by using sevens. So like 70, 63, 54, 56, 49, 42. And so you have them count backwards. That takes a lot of attention to do. And so if they can't complete that, they might have a poor attention span. Be unable to perform daily routines. These are also, you'll see these written as ADLs, or activities of daily living. Show a decreased ability to communicate, appear confused or angry, have impaired judgment. What's impaired judgment, right? So they may, you could see, actually, I'll just tell you, in certain forms of dementia, you could see someone who masturbates in public, right? Or someone who walks out in the front of traffic, right? Their judgment is impaired, right? So they almost can revert to children. Like children have impaired judgment. Like a 5-year-old has impaired judgment. They don't know right from wrong. They don't really understand the consequences of their actions. And so this can also happen in dementia, where you'll have impaired judgment. And then all of that, you could have impaired financial judgment, where they make really bad financial decisions or fall victim to scam. So be unable to vocalize pain. So again, these patients, and especially late stage dementia, can have could have a decreased ability to communicate. So they can't communicate, oh my God, my leg hurts, right? And so be aware of that as well. Now, delirium is acute. Notice the word sudden. This is sudden. Change in mental status, consciousness, or a cognitive process. And so you can see delirium in older people, but you definitely could see delirium in someone like me. But you could not see dementia in someone like me. I'm like my age. And so just be aware of that. So it's the sudden change in mental status, consciousness, or cognitive processing. It's marked by the inability to focus, think logically, and maintain attention. So think about this. You could almost think of someone who's drunk. They could be in a state of delirious. It's really more psychosis, but delirious, right? To where they're not able to have a clear mental status, be conscious, cognitively process it, think logically, maintain their attention, right? And so it affects 15 to 50% of hospitalized patients at age 70 or older. What does that mean? That means someone could come into to the hospital for a heart attack and they're 70 years old and they don't have dementia yet, but they become delirious. They have delirium while in the hospital. And so that's fairly common, actually. Okay. And so they can also be very anxious. And this is very, very common in the hospital. Very, very common. Now, generally, the results are reversible. So, what does that mean? The guy that was delirious in the hospital, 70-year-old with a heart attack, when he goes back home, they should go away. Okay. And so, or you reverse the heart attack, or whatever. And so, um, metabolic causes, fever, medicines can all cause this states of delirium. So the most common cause of this, I would say, well, I would say the most common. I shouldn't say that. I don't know this. But a very common cause of this is withdrawal. So when someone withdraws from alcohol, they can have what's called delirium tremens. Remember, where they shake, they can have seizures, they're delirious. And so this is because alcohol is a form of GABA, which is a depressant. When you take away that depressant, your body's not producing enough of this depressing chemical known as GABA. And so when you take that away, the brain's like, wow, it's all hyper and stuff. So you start shaking, you get delirious. And same thing with sedatives like Xanax, lorazepam, Ativan, all those guys. If you suddenly stop taking those, you can end up with delirium tremens, seizures. It's a bad deal. Okay, and so it's a serious thing. When someone stops drinking alcohol or abusing prescription drugs like that are sedatives, um, it's usually done under the care of a doctor because of the risk of these disorders. They can it can kill you. And so medical conditions, of course, hypoglycemia, hyperglycemia, hyperthyroidism, hypothyroidism, right? The list goes on and on. Hypoxia can cause a state of delirium. Okay, so any type of cause, anything can cause delirium. So this is just think the brain is irritated, right? And so you can see this. Depression is astronomically common in old people. Okay, so be aware of that. Very, 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 very common diagnosis in old people. Malnutrition or vitamin deficiencies can cause this. The one that you have to worry about most, we've talked about this before, is vitamin B1, also known as thiamine. Oh my gosh. I don't even know why I write that. I couldn't read that. Environmental emergencies. So assess and manage the patient. So remember, delirium is reversible. Dementia is not. Delirium is reversible. It's sudden, short-term, reversible. And so you could see this in hypoxia, and you give them oxygen, and they're suddenly not delirious. Okay, and so same thing with hypovolemia. So someone's been pooping and vomiting their blood out, or I'm sorry, their fluids out, and so if you correct that with fluid replacement, whether it's through an IV or orally, they're going to come back to normal. Hypoglycemia, right? You give them a little oral glucose in the buccal cavity and suddenly they're normal. Hypothermia, right? You'll see all of these are all reversible causes that we can treat. And so you may see changes in circulation, breath sounds, motor function, and the pupillary response with delirium. And so delirium is you could simplify delirium. Delirium is a sign of shock, right? So you're going to see delirium, shock, 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 right? If you reverse these causes of shock, delirium should go away. Now, syncope, not syncope, syncope, okay, I didn't spell it, is the medical word for fainting, okay? And so, especially in old people, but really, I'd say anyone, this is assumed this is a life-threatening problem until proven otherwise. And so, there's several causes of why this happens, but, basically, blood flow is being reduced to the brain for whatever reason. So let's talk about it. So a dysrhythmia is the most common, I would say the most common, the most serious probably, because the heart can be beating 250 times a minute, so there's not enough blood going up to the brain, so they're gonna pass out, right? So it's syncope. Same thing if the heart has failed because like a heart attack, the heart's dying, syncope. Okay. Now this is very common. This is probably the most common one actually, but not the most serious. And so basically, what happens is, so you've probably experienced this. Have you ever like been way hangover, or you've had food poisoning, and you're throwing up over the toilet, and you try to stand up, and like you suddenly get real dizzy, and your vision gets real dark, or it might become tunneled. That's a near syncope, right? Near fainting. This is because you don't have enough volume in the system because you've just vomited it out. And so you see this really common with patients that are hypovolemic. And so what you'll see is when a patient, and what's the test to test this, right? Orthostatic hypotension. Okay, so when the patient goes from laying to sitting or sitting to standing, right, you'll see the pulse rate increase by like 10 to 20 beats per minute, and you'll see the systolic blood pressure decrease. Okay, so how do we test that? We have the patient lay flat, right? You take their vitals, wait a few minutes, then you sit them up, then you immediately take their vitals again. Okay, and so if that has increased, if the blood pressure has decreased and the heart rate has increased, that means that you're positive for orthostatic hypotension, which likely means that they're hypovolemic. And the most common cause of hypovolemia is going to be what's it called? Vomiting and diarrhea. The most serious cause of hypovolemia would be hemorrhage, right? And so just be aware of that. Okay. Now, the neurologic cause of syncope, this could be like a transient ischemic attack or a stroke or something like that. Okay. So syncope is very serious. Okay, very, very serious. In fact, I had a lady, I don't know why I remember this. It was many years ago. I stood her up in Springtown. She had vomiting. And I literally, like, all we did, we had a hand underneath each arm. All we did was stand her up and set her on the stretcher. And just the act of her standing, for like not even fully standing, we're helping her and just setting her on the stretcher, she passed out for like 30 seconds. And so, that's just the act. I mean, just that much of a change. And so what happens is when you stand, your vasculature, if there's not enough volume, not enough liquid in the system, the blood will seep kind of seeps from your head and your brain. And so again, when your brain doesn't get what it needs, it stops working, and so they'll pass out. And so let me say on this one, if that happens, then you would put them in Trendelenburg, right? So you would elevate their feet. And so neuropathy, I've already talked about this. It's a disorder of the peripheral nervous system. And so this is most common in who? Diabetics, also people with peripheral vascular disease, like peripheral artery disease, stuff like that. And so basically the nerves are very sensitive. And so if they get too much sugar, they don't get enough blood, they're not going to work. And so when that happens, you can end up with pretty severe pain or just tingling sensation like paresthesias or, hot cold sensation, pain, numbness, tingling. You will end up with neuropathy, right? This literally means pathology of the nerves. And so it's very, very common where you typically see this is in the extremities. In my experience, it's typically in the lower extremities first, and then a more severe patient will have the lower extremities in the hands. Okay? And so just be aware of that. Changes in the gastrointestinal system. You'll have a reduction in volume of your saliva, dental loss. So it's not uncommon for patients to lose their teeth, have false teeth, dentures, implants, etc. Gastric secretions are reduced. This includes stomach acid. This also includes like amylase, lipase, stuff like that produced by the pancreas. There's changes in gastric motility. So, gastric motility is like the peristalsis that's kind of squeezing these tubes to move your Taco Bell all the way from your mouth to your stomach to your rectum. Okay, and so that's done through a coordinated motion called peristalsis, where it's squeezing like this to move it along. Incidence of certain diseases involving the bowel increase. So obviously cancer, also like ischemic bowel disease, ischemic colitis, all those issues. Blood flow to the liver declines. There's just, getting old sucks. And so age-related change in the GI system, again, so there's GI, they just said this. Let me just tell you the ones they didn't say. Is poor muscle tone in the sphincter between the esophagus and the stomach. So the stomach holds, obviously, food, and it's a very harsh environment. There's acid in there and food. And so there's normally, remember, round muscles are called sphincters. Well, when we swallow, that sphincter opens and immediately closes once food passes. Well, as we get older, this sphincter relaxes, and it can relax so much it can allow stomach acid to shoot back up through this open hole into the esophagus. We call that heartburn, or it's called gastroesophageal reflux disease, also known as GERD. And so this is very common in old people. In fact, you're starting to see this a lot in young people. And so, it's uncomfortable. The patient usually won't want to lay flat. They'll have heartburn with certain foods like spicy, acidic foods, tomatoes, stuff like that, coffee, caffeine. Now, there's a decrease in the hydrochloric acid. Again, that's the acid in the stomach that digests food. There's alteration in absorption of nutrients. So these nutrients aren't just sucked up like you would think. There's actually usually precursor chemicals like intrinsic factor and stuff like that are released to pick up these things within the stomach and the bowel. So that's decreased as we age as well. And then there's weakening of the rectal sphincter. So there's two sphincters in the rectum. One's you can control consciously, the other one you cannot. And so the one that you cannot control will become relaxed with age, just like the one in the esophagus is around sphincter. So it can relax so much you can have anal seepage, right, or incontinence, right, where you end up pooping your pants. Okay, very common. Incontinence is fairly common in older people. For many reasons, that's just one of them, the relaxed sphincter. Now, GI bleeds can be caused by inflammation, infection, or obstruction of the upper or lower GI tract. Okay, I'd say usually, but is often heralded by hematoemesis, which is vomiting blood. But bleeding that travels through the lower digestive tract, so like a stomach ulcer that makes its way all the way to your rectum, that's going to come out as something known as melena or melena. That's this word right here. And so this is a tar-like substance. You know the tar they put on the road? It looks like that, and it smells I've never smelled poop that smells good, but it smells really, really bad. Okay, very distinct smell, and it's very thick tar-like. Okay, now what happens if someone vomits blood? Same stomach ulcer, but now they're vomiting partially digested blood. What is that? We call that coffee ground emesis. It literally looks like you took the coffee grounds out of the coffee filter and threw it up in the toilet. Okay, so it looks like that. And that means that they have vomited blood that's partially digested. It will not be red, it'll be blackish brownish. Now, red blood usually means a local source of bleeding, such as hemorrhoids, also a common cause would be cancer. And so this can create something, this is not me being fancy, called hematochezia. And so this is obviously poop with blood mixed into it. So this could be from a hemorrhoid, okay? And so a patient with GI symptoms may experience weakness, dizziness, syncope. Okay, so you have to worry about blood loss. In fact, any patient that's passing blood over the age of 50, it's presumed cancer until proven otherwise. So this is why you get colonoscopies at age 45, starting at age 45, because of the risk of GI cancer. And so yeah, you can get blood loss that can lead to anemia and all the issues with anemia like weakness, dizziness, syncope. And so specific GI problems in older patients include diverticulitis. So the colon's shaped like this. Okay, and remember the small intestine feeds in right here. Okay, and so this is called the transverse colon, or I'm sorry, the ascending colon, the transverse colon, the descending colon. This is the patient's right. This is the patient's left. This is called the sigmoid, and this is called the rectum. Well, what happens in this S-shaped piece right here, you can get what's called a diverticulosis. And so this is going to be outpouching, right? So instead of being like a tube, it outpouches like a little ball. And what causes this is constipation, by the way. So it's very important to have a diet rich in fiber, okay? This is terrible. I literally did surgery on two 20-year-olds last month that had this, and we ended up chopping out this section of their colon, okay? Very important to not get constipated. Okay, but anyways, what happens is that's called diverticulosis, the outpouching. Okay, it happens. What causes it? Constipation. But the question is, what is diverticulitis? Well, what happens is this little outpouching will get infected. And so when it gets infected, it's extremely painful. And so you have to give the patient antibiotics. They usually have to get hospitalized, bowel rest. This can cause a perforation, sepsis, all these issues. It's so adhesions, all these issues can present. So just be aware, that's called diverticulitis. It is inflammation of an outpouching of the large bowel, typically in the sigmoid, almost always in the sigmoid, usually due to constipation that will become infected. And so it presents with severe left lower quadrant pain. Okay, it can also present with peritonitis. Okay, so this is the patient, they'll have fever, left lower quadrant pain. Bleeding in the upper and lower GI system. Again, you could have an ulcer, cancer, whatever. An infection like H. pylori, whatever. Peptic ulcer disease. Again, these are ulcers within the stomach or the duodenum. Gallbladder disease. So we've talked about this. Who gets gallbladder disease? It's the 4S. Fat, female, fertile women, females. Fat, female, 40, and over 40, sorry. Fat, female, 40s, over females. Why can I say that? Fat, females, over 40, and fertile. Because if you're fat and you're fertile, that increases estrogen. If you're over 40, you have a likelihood that the gallstones have built up in your gallbladder, and then females have estrogen. So estrogen plays a big role into that. And so how does gallbladder, like cholangitis or cholecystitis or cholelithiasis present? You could or could not have fever, it depends, but typically it'll present with pain after eating. It is like a colicky pain after eating, often associated with nausea. You get a right upper quadrant pain that rotates to the back. Okay, that's the classic presentation. And a bowel obstruction. So this can be from, again, cancer. It could also be from constipation. Constipation is very, very common. And the reason you see constipation in old people is because typically they are dehydrated. And so you have to be hydrated for enough liquid to go to your bowels to be able to hydrate your poop to shoot it out. One. Two, dietary changes, and then just the decreased gastric motility. So just be aware, like, you don't want to get constipated. So eat your fiber gummies. I know I do. And so changes in the gastrointestinal system. When assessing patients, you should ask about NSAID and alcohol use. Both of these increase the risk of a stomach ulcer or what's called peptic ulcer disease. Okay. Orthostatic vital signs can determine if the patient's hypovolemic. I've talked about that. Remember, that's when the patient sits up and their blood pressure will drop, their heart rate will go up. And then treatment consists of airway, ventilatory, and circulatory support. Now, this is a fairly uncommon but life-threatening diagnosis called a AAA. And so let me talk about this. So, okay, let me read these first two. Extremely difficult to assess in the pre-hospital setting. So abdominal complaints are actually really difficult to diagnose, even with like all the imaging and lab work and, even sometimes surgically, right? You open it up and you're literally looking. It can be very difficult to diagnose. So let me start with that. Two, these can kill you, okay? For infection, blood loss, obstruction, whatever. But a AAA, right, not the car insurance, but a AAA, also known as an abdominal aortic aneurysm, okay, a AAA, is one, and it's not called an AAA, so don't do that. It's called a AAA, is one of the most rapidly fatal conditions. And so basically, actually every patient between the ages 65, I think it's like age 65 and older who has ever smoked, you're supposed to get a sonogram of the stomach to look for this because it's that fatal. And so what happens is you get ballooning of the aortic, the aortic the aorta in the abdomen. This guy. And so what happens is this will get ballooned. And so if it balloons so much and it ruptures, like it literally explodes, you're going to die very quickly. Okay. Now it could also tear. We've talked about this, where it could tear in the layers. And that's a possibility too. But this is pretty common in patients that have smoked. And so another reason not to smoke. And so you can end up with a AAA. And so the patient will present with severe obviously abdominal pain, that they need to defecate. They'll feel like they need to poop. And so it'll just kill you. Rapidly, and if it's ruptured, you usually can't even fix it surgically. You just die. And so the age brings changes in the kidneys. So there's going to be a reduction in renal flow. So with that, there's reduction in renal blood flow. The tubules will degenerate. And with that, you really have to worry about something I'll point out. You have to worry about medicine excretion. Okay, so when we give medicine, almost all of them, not all, but almost all, are excreted through the kidneys, meaning we eliminate them through the kidneys. And so if your kidneys have slowed down, you have to worry about holding on to that same Tylenol for longer than I would because my kidneys are working. And so this is something to think about. So usually you change the dose with old people and those with renal failure. And so there's changes in the genitourinary system. So you have decreased bladder capacity. The bladder is smaller, is less stretchy. There's a decrease in sphincter muscle control. Again, this leads to incontinence. What is incontinence? This is accidentally pooping or peeing on yourself. Decline in voiding senses. They don't know when they need to go. This can lead to accidents, also known as incontinence. Decrease in nocturnal voiding, or an increase in nocturnal voiding. This can happen for several reasons, but the most common one, especially in men, is this. And so if you don't know, here's your bladder. And right below your bladder is the urethra, and this will go out to like the penis, okay? This is all the urethra. Well, what happens is you have this little gland that sits around the urethra called the prostate. It's only in men. And so as we age, this over the last 75 years or however old the patient is, it has been exposed to testosterone. Well, as the prostate is exposed to testosterone, it grows in size, it hypertrophies. It becomes bigger and bigger. Well, it can become so big, it starts pushing on this urethra. So this is where people can get what's called benign prostatic hypertrophy. to where the common signs and symptoms of this is difficulty voiding, so they have a hard time starting peeing. They have an interrupted stream, so it's like start, stop, start, stop. They can't fully empty their bladder, so they have to wait for the pressure to build up really big in the bladder to squeeze it through that tight prostate that's squeezing on the urethra. You can also see what's called nocturnal uresis, where they urinate at night. So this is very, 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 very common in men that are old, and it's from a lifetime exposure of testosterone. Now, there are medicines to fix this or at least treat it, but they're treatments, not cures. Okay? No, incontinence is not a normal part of aging, can lead to skin irritation, skin breakdown, urinary tract infection. And I would agree, it's not normal, but it is common. Okay? And so keep in mind, poop and urine, your body wasn't really designed to have that sit on it like that. And so you can end up with infections and skin breakdown, especially if you sit in that for a long period of time. Like a bedbound patient sitting in poop for 8 hours, you can imagine what that will do to the skin. And so just be aware. Now, stress incontinence is where someone coughs, sneezes, laughs, exercise, lifts something, and the sphincter that's normally holding pee inside your bladder and your urethra is not strong enough. So when you bear down because you're coughing or laughing, the pressure in your bladder was strong enough to push it out the end of the sphincter, and so you can end up with leakage. Very common. Urge incontinence is different, and so this is when you have the urge to urinate. So this is like someone putting the key in the door and they're trying to get to the bathroom in time and they end up voiding. Or this is someone who like hears the sink running and they pee their pants, right? And so this is actually very rare. I mean, this is more common in multiple sclerosis, by the way. But anyways, this is that's rare. That's not as common. Stress incontinence is much more common. You know, stress incontinence can be fixed with Kegel exercises. Fun fact. So a Kegel exercise could fix that, or help fix it. The opposite of incontinence is urinary retention or difficulty urinating. So you can get what's called a hypogenic bladder, and so well, let me just tell you. In a man, enlargement of the prostate again can cause to where the pressure has to build up in the bladder high enough to be able to push past that obstruction. Okay, and so that's a problem. That can lead to infections, hydronephrosis, kidney infections, all these issues. But the bladder and urinary tract infections can also cause inflammation, and so in severe case of urinary retention, patients can experience renal failure. This is a consequence of BPH, right? And so that can happen to where the kidneys can fail because there's so much fluid backing up into the kidneys because it can't come out the bladder. So changes in the endocrine system. So very common for old people to have a reduction in thyroxine, which is a hormone produced by the thyroid. And so when this decreases, we call it hypothyroidism. So everything is low in hypothyroidism. So they'll be cold, they have a low heart rate, they're weak, right? They could be depressed, not want to eat, stuff like that. And so that's what they're telling you here. So heart rate, fatigue, dry skin and hair. It's actually a common they won't have hair in the lateral third of their eyebrow. Brittle skin or brittle hair that breaks easily, cold intolerance, weight gain. Okay. What's cold intolerance? That means they don't like the cold. So they're always cold. They're always complaining. It's too cold, right? If you ever been to a nursing home, they say that, right? It's too cold. It's too cold. So I make it rain blankets for my old patients. They love it. Old patients love blankets. Give them the blankets. Give them all the blankets. Other endocrine changes include an increased secretion of anti-diuretic hormones. So remember, to diurese means to pee. So ADH is saying this is the don't pee hormone, so you can end up holding on to fluid. And so that can cause a fluid imbalance. Hyperglycemia, so remember, type 2 diabetes mellitus can progresses with age. It gets worse and worse. And so you can eventually become, a beginning type 2 diabetic can control it with pills, but as their pancreas fully burns out from insulin resistance, you can end up with having to take insulin even in type 2 diabetes. And so, that's a consequence of type 2 diabetes. You can end up with hyperglycemia. Increase in levels of norepinephrine, possibly having a harmful effect on the cardiovascular system. This may be one of the reasons you see hypertension in old people, but also there's a change in receptors on the vessels, and so long story. We've talked about this, and so remember, type 2 diabetes is where the cells become resistant to insulin, so the pancreas produces more insulin, to try to force the sugar into the cells. Well, eventually the pancreas will become burnt out. And so the pancreas is like, I ran my race, I'm dead, I'm done. And so the pancreas will quit working. And so when that happens, we have to give them insulin because it's like type 1 diabetes where there's no insulin production. And so in late stage type 2 diabetes, you'll see the pancreas burnt out. But before you reach that, you could end up with this condition called hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS. And so basically, this is where the patient will have a blood sugar of like 500 plus, and they have the polys, right? Polydipsia, polyuria, polyphagia. So polydipsia meaning they're drinking a lot, polyuria, they're urinating a lot, and polyphagia because they're eating a lot. And so this can lead to the problem with this is you end up with dehydration, because remember that glucose has an osmotic pool, so it takes water with it. So the water in your cells will follow this sugary water, and so it sucks the water out of your cells, and your kidneys will be like, oh, cool, extra water, and so you pee it out. And so you end up with dehydration. Dehydration is the main issue with this. And so you end up with warm, flushed skin, poor skin turgor. Remember, skin turgor is where the tinting of the back of the hand, when you let go, it stays tinted when they're dehydrated. Dry, pale oral mucosa, right? So I tell them, open your mouth, stick out your tongue, it's all dry. Uh, a furrowed tongue. This is where the tongue has ridges in it. Saw this actually last week in the clinic on a lady that we started an IV on in the clinic. Young too, in her 30s. And signs of shock. So this can lead up to hypovolemic shock. And so, assessing the patient should include obtaining a blood pressure, just a pulses, auscultation of breath sounds, temperature, assessment of the blood glucose, right, if you're allowed to. And treatment should include airway, ventilatory, and circulatory support. Now, changes in the immune system. So infections are common in older people because of their increased risk. So the immune system's a lot slower to respond. It's not as robust, not as powerful as we age. And so they're less able to fight infections, And so with these infections, you can see anorexia, which literally means the fear of eating, or and not desiring to eat, fatigue, weight loss, falls, change in mental status, can all be the primary symptoms, okay? And so pneumonia and UTIs are the most common causes are common causes in patients who are bedridden. Signs and symptoms may be decreased because of loss of sensation, lack of awareness, or fear of being hospitalized. And so this last one we haven't really talked about yet, but believe it or not, there's patients that are afraid of the hospital, and so they don't report their symptoms to their doctor or to you on the ambulance or the clinic or wherever because they do not want to go to a hospital. And so you'll have a decrease in bone mass, especially in postmenopausal women, okay? And so what do we call that? It's called osteoporosis. And so the bones become more brittle and break. I put a picture in here. Let me just show you this real quick. And so this is a normal bone. These are called trabeculae within the bones. It's this web-like pattern. And so that's what's normal. But in old women, estrogen's a protective factor of this. And so when you are postmenopausal, you end up losing estrogen. And so these little osteoclast Pac-Man guy will go in here and eat up your bones, basically. And so this is a common cause of this is why women are more likely to have brittle bones. That disorder is called osteoporosis. And so remember, osteoporosis is an old woman disease where they have brittle bones. So what does a brittle bone sound like? It's like a brittle stick off of a tree. It's going to snap really easily. And so keep in mind, just in general, for all old people, joints will lose their flexibility. Okay, so this is why joints don't dislocate; they break. Okay. So you could snap a tendon, snap a ligament. They're not going to dislocate and still be attached. They're just going to snap. A decrease in the amount of muscle mass often results in less strength. Changes in physical abilities can affect older adults' confidence and mobility. Muscle fibers become smaller and fewer. Motor neurons decrease in number. Their strength will decline. I know I'm reading this to you, but I don't have a lot to add. The ligaments and cartilage of their joints lose their elasticity, so they're more likely to snap. Cartilage goes through degenerative changes. Remember, there's cartilage in joints. I would say probably very importantly is in the vertebra, right? So, if these are a vertebra, in between each one are these little disc of cartilage. And so as we age, these become thinner and maybe sometimes non-existent, or they herniate. And so you have to, this is why old people get all sorts of back problems. Is one of the many reasons is the cartilage. You can also get I'll just tell you, you can get what's called a compression fracture. Old people with osteoporosis Remember, osteoporosis, their vertebrae are brittle. And so a very minor fall or something like that can cause this to fracture. And so you can fracture the vertebra in old people, and that's called a compression fracture. And you see that very commonly in patients with osteoporosis. Who gets osteoporosis? Old women. Can men have osteoporosis? They can, but you're going to see this more commonly and earlier in age in women. And so, let's see. The extent of boat loss will depend on the genetics, body weight. Okay, so in fact, you see osteoporosis again. Estrogen is a protective factor. So in thin, skinny women, if you don't know, fat equals estrogen, by the way, especially in women. And so women that are skinny, they have less estrogen. Again, estrogen is a protective factor. And so when you take that away, they can end up with osteoporosis. And so smoking, alcohol consumption, and low activity, right, can all lead to increased risk of osteoporosis. And so osteoarthritis is different. This is you need to know, say it with me, class, wear and tear. This is a wear and tear disease of the joints, okay? So they're worn out, okay? And so your hands, your elbow, your knees, right? That's osteoarthritis. And so the cartilage have been destroyed, the joints have been destroyed, and so you can get bone spurs and stiffness and pain and swelling. And this is, oh, they even put it in here. This is a wear and tear disease. Okay, so pretty much all old people have some degree of this. Some is more debilitating than others, but typically this will affect the hands, knees, wrists, joints, spine, stuff like that. Okay, very, very painful, very annoying disorder, unfortunately almost inevitable. Now, who's at a higher risk of osteoarthritis is obese people because they have more weight that is wearing and tearing those joints. Changes in the skin. So the skin becomes less elastic with age. And so, my skin, you could pretty yank on it, pinch it, stuff like that. It's not going to tear. But old people, their skin will literally tear like a wet tissue paper, okay? And so it will literally just tear. And so this is where you got to be careful using like blood pressure cuffs and like a tourniquet to start an IV, stuff like that. You'll just, or even picking a patient up off the ground and grabbing their extremities, you can literally just come back with a handful of skin if you do it wrong. Because you've torn their skin. And there's less fat under their skin. Bruising is much easier, more common. Again, the vessels are closer to the skin or to the external. The vessels are more fragile. They're less elastic, so they're more likely to rupture. Also, sweat glands do not respond to heat as easily. What does that mean? Okay, I can go outside and work in the 100-degree heat all day. I don't want to, but an 80-year-old lady may not. Okay, and so they're not going to be able to sweat and cool off by evaporation, convection as easily as I would. So they can't sweat, so they can't thermoregulate the heat very well. Also, keep in mind they have less fat, so we know fat keeps us warm. Okay, when we're cold, and so they're more likely to suffer from environmental injuries and environmental factors of the extreme heat and the extreme cold. And in fact, I should delete the word extreme, just the heat and the cold. Okay. Now, these are very common and extremely grody, but you'll see them. And so these are called the technical word for this is called a decubitus ulcer. And so these are also called pressure ulcers, bed sores, or a decubitus ulcer. I should do a better job of just reading that instead of writing it. But anyways, that's what they're called. All three names. Bed sore, pressure ulcer, decubitus ulcer. They all mean the same thing. And so what happens is, let's just imagine you have a patient laying in a hospital bed, intubated, or they can't move, right? They broke their hip. And so what happens is this is very odd to think of if you've never heard of this, but bear with me. So what happens is if you have a steady pressure on something in your skin, let's just take it right here, right? I put a steady pressure here, right? I'm pushing the blood out from this area, and that's why it blanches and turns white, okay? Okay. Well, if you were to keep this on, like this for 4, 5, 6, 8, 10, 12, 24 hours, and I already have, more thin skin, less elastic skin, less fat barrier, this tissue could become injured and necrotic, okay? And so what happens is you can end up getting something called a decubitus or a pressure ulcer. It's from pressure. And so where do patients in this, so this is when the weight of the body cuts off blood flow to an area of skin. And so with no blood flow, inflammation will occur or will try to occur, but eventually necrosis is going to occur. And so how this presents is this way. These are real pictures. You will see this. Um, and so imagine this. This is the patient's heel. What? Their heel? There's not even that much weight on the heel, but yes, their heel. It's just sitting in a bed. And so that they didn't move for such a long period of time. They ended up with a decreased blood flow here because it's pushed against the bed and it didn't move to allow, like, you know, I'm squirmy, but I'm always moving and stuff, getting more comfortable. But if you can't move, and if you have decreased sensation down here, you won't know something's wrong. And so you'll end up with a pressure ulcer. So the stage 1 pressure ulcer is where the skin stays red all the time. Okay? And so you're going to see this most commonly in places like the heel, right above the butt crack where the sacrum is. You'll also see this on the butt cheeks. You can see this on the shoulder blades. You can see this in the back of the head. You can see this on the tips of the toes from a bed sheet or a blanket. Yes, just the weight of a blanket pushing down on the tips of the toes can cause this, okay? And so that's a stage 1 ulcer, it's red. A stage 2 is where it starts to ulcerate, okay? It actually is sloughing, okay? So you can see this is right above, there's the butt crack right here, right? Butt crack's here. So it's right here in the sacrum, okay? This is where it's fully ulcerated into the fat tissue. You can see it's on the fat tissue. This is a stage 3. I'm not going to test you on the stages. I'm just letting you know what these are because it's on the next slide. And then a stage 4 is all the way down to the bone. This is bone right here, folks. It's very severe. I have seen them this severe. And so if you've ever been to a hospital, you'll see that they rotate the patient every 2 hours on their left side, back, right side, left side, right? They're constantly rotating them to get pressure off of their body, okay? And so this is a very serious condition that leads to very, very severe wounds. Imagine this is your butt crack, right? How long is it going to take to get this to heal? Forever. Months to heal with extensive wound care, surgery, wound vacs, debridements, antibiotics. It's a mess. It's a mess. What's right below that? The butt, right? So if they're incontinent and they poop into that, I mean, you can imagine all the issues that come with this. So it's a huge issue. So hospitals get dinged on this. If a patient acquires one of these while in the hospital, they get a huge fine. Huge, huge, huge fine. And so this is why they take it so seriously. Almost done. We have like 3 slides. I hope. I need a break. Okay, 6 slides. I lied. Older people. So toxicology. So we talk about older people are more susceptible to to being toxicity. So remember, if this is the normal dose of a medication, all right, and then we have something called the LD50 or the TD50, right? And so this is what's saying like, okay, well, this isn't a good example. Saying this is what normal people can give. So somewhere between, oh yeah, this works, and oh yeah, this is toxic is somewhere in here, and that's called the therapeutic index. But old people, this line can be moved tighter in, right? And so basically from what works and what's toxic becomes more narrow. And so the therapeutic index of medications shrink. 1, 2, the elimination is decreased. So again, things are eliminated through the kidneys, okay? And so the kidneys don't work as well as we age, so that's issue number 1. Issue number 2 is you can end up with the liver does not have as rich a blood supply, so you don't metabolize medicines as well. And so all these issues go into it. And so decreased liver function makes it harder for the liver to detoxify the blood and eliminate medications and alcohol. And so typical over-the-counter medications can have negative effects when mixed with other medications or with see this all the time, herbal substances, alcohol, prescription medications. All these old people are all into like the cinnamon and the garlic and the turmeric. And I'm not hating on that as a whole, but, lady, you can't take your cinnamon and warfarin at the same time. And so, you can't take your St. John's wort and selegiline at the same time. And so just creates all these issues, and so you got to be careful with that. But, I'll just give you a very common example that you may not know, but the drug Benadryl is a no-go for old people because they can have nasty anticholinergic effects. They can get delirious and dry and fall, and so, this is why we don't prescribe routinely for long terms like Benadryl or anticholinergic drugs like hydroxyzine and stuff like that to old people. Because they get delirious. And that's just one example. It's an over-the-counter medicine that, some patients may take for, there's a fly that, why is there a fly in my house? That might take these drugs thinking, oh, it helps me sleep. But, you do that long enough, you can end up with anticholinergic effects and all these issues. And so polypharmacy is what it sounds like. Poly means many and pharmacy means drugs. And so they're taking a lot of prescription drugs. And so, the problem is you get all these different drugs and some drugs interact with others. I see this all the time in the clinic where, oh, their oncologist prescribed this, but we're prescribing that. Oh, and then their weight loss doctor prescribed this and the surgeon prescribed that. And it's like, holy cow, like all these drugs are not working well together. And so you end up with overdosing and all these negative interactions and stuff like that. And so, not only that, you get these medication non-compliances with financial challenges. So drugs are very expensive in the United States, unfortunately. If you don't believe me, go to Mexico and see how cheap they are there. Same drugs, like one hundredth of the cost. And then not only that, just the insurance shenanigans of this, right? Like, oh, you got to get a prior auth. Oh, my pharmacist said I have to wait a week to pick this one up because it's not time, but they're already out. And just all the financial issues with this. So, you know, I love old people will say, oh, I'm on a fixed income. Everyone's on a fixed income, but old people are especially on a fixed income. And so, if they have to decide, am I going to eat or am I going to take my $500 Eliquis? A lot of times they'll choose to eat. And so they're not compliant with the medicines we prescribe. It's very, very sad. Should not happen in 2024 in America. And so the inability to open the containers or impaired cognitive vision or hearing ability, so they misdose, they don't take the right pills every day, they don't understand the instructions from the doctor or the pharmacist, things like that. Okay. Now, depression, very, like I said, very, very common of in older people. It's not normal to be depressed, but it's common. So just because I'm telling you it's common is not like just like old people that have incontinence. It's not normal, but it is common. And so, we can treat this with medication and therapy. You have pretty good response to this, so you can give like SSRI, stuff like that. And so, um, if depression goes unrecognized or untreated, it is associated with a higher suicide rate in the geriatric population. So, think about this. You've been married 50 years and your spouse dies, and your kids live two states away, and now you can't drive, and you're dependent on meals and on wheels, and that can be very sad, very depressing. And so you see depression fairly common in older people. And so risk factors for depression include a history of depression, chronic disease, and loss, right? So again, you've lost a kid or a spouse or something like that. And so the following conditions contribute to the onset of significant depression. So substance abuse, being isolated. Again, kids live in a different state, husband died, something like that. Prescription medication use, chronic medical conditions, the risk of depression after an MI is like 80%. So 80% of patients that have a heart attack will have depression afterwards. And so these chronic illnesses lead to sadness and depression, okay? Now, sadness is a very normal and valid emotion. We should all be sad at some point, but uh, remember, depression is prolonged sadness that interferes with activities of daily living that lasts for more than 2 weeks or 2 months. I think it's 2 weeks. And so older men have the highest suicide rate of any age group in the United States. And I've seen this. I've seen 80-year-old men shoot themselves in the head when leaving the oncologist's office. I've seen 80-year-old men hang themselves, overdose, uh, all sorts of stuff. And most commonly, they just shoot themselves in the head like an old revolver. It's very sad. And so be aware of that. Um, they're at a high risk of suicide, unfortunately. Generally have yeah, and so I've seen people shoot themselves in the head and live. It's rare, then and they're in their 20s. But an 80-year-old man that shoots himself in the head is not going to live. Period. They will die. And so common predisposing events for conditions include death of a loved one. So you see this quite often where I've seen the wife dies and the husband decides to shoot himself. So you go there, wife's dead from like a medical cause, and the husband walks in, found her, and shoots himself. Physical illness, depression and hopelessness, alcohol abuse, alcohol dependence. Remember, if you're dependent on alcohol, it means you need it to get through your day, to not get sick. If you withdraw, you'll get sick. Loss of meaningful life roles. And so you'll see this too. Say your identity is a firefighter, right? And or a police officer or whatever, a boss, whatever, a teacher. And you retire, and that suddenly that part of your identity goes away because you're not doing it. You've lost your life role. And so it's very sad. People feel So sad that they feel that the only way to fix that is to kill themselves. So, very sad. Now, when assessing the patient who is displaying signs and symptoms of depression, it is important to ask if he or she has considered suicide. This is a very hard question to ask, but you have to be very clear about it. And so, the very clear way to answer or to ask this: have you had any thoughts of hurting yourself or anyone else? Right? And if they say yes, I have had these thoughts, your very next question is, do you have a plan? And if they say yes, I am planning to shoot myself tomorrow night, or yeah, I'm planning to take all of my Xanax, then obviously that has to be reported to authorities. You do not have the right to try to kill yourself in Texas, and so what we do is they would get what's called an apprehension or detention. I'm sorry, to where we would if they don't agree to go to a psychiatric hospital, we would detain them for 3 days, 72-hour hold, where they would have to be evaluated by a mental health expert and determine if they're at risk and seek treatment or not. Okay. And so, of course, suicide of any age group is a mandatory reporting to law enforcement, and obviously, a patient who is suicidal or homicidal cannot refuse medical care. Oh, that's it. That was a long one. The next one talks about patient assessment, trauma, and then some 10 questions at the end. So I appreciate your attention.